Good evening. My name is Roxanne Chabot from RBC Consultants. Welcome to our webinar. This evening, we're going to be talking about a topic that we don't often talk about in dermatology, but really crucial to dermatology. That is medical photography in the age of smartphone cameras. As speakers, we have Dr. Neil Batea, Director of Clinical Dermatology at Therapeutics Clinical Research, and also Dr. Danielle Siegel, Clinical Professor of Dermatology at SUNY Downstate. We would like to thank our sponsor this evening, La Roche-Posay Laboratoire Dermatologique, for making this educational event possible. Just a couple of logistic tips before we begin. If you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane and the dial-in information will be displayed. If you're having technical issues or if you would like to submit a question to our faculty, please submit your question in the question chat pane on the right-hand side of your screen. At the end of this webinar, a survey will pop up in your web browser following the webinar and will be emailed to you 1 to 2 days after the webinar. We truly appreciate it if you could fill out this short survey. Finally, within 1 to 2 days of the webinar, the recording of this program and a certificate of attendance will be emailed to you. Again, please submit your questions using the question chat pane on the right-hand side of your screen, and I wrote a little note there so you can see where you need to type in your questions. So without further ado, I will pass the floor virtually to Tyler Steele, who's Vice President, Medical and Media Relations for La Roche-Posay.
Hey everyone, thanks Roxanne, and boy Roxanne, you've got to teach me some French because I've worked on La Roche-Posay for 9 years and I can't say it as good as you can. We've got a great group of people here tonight. We're upwards of about 500 people, and we've got a great talk for you. I just wanted to share a little bit about La Roche-Posay. We are a brand that started out of a dermatology center in France that treats up to 8,000 patients a year using balneotherapy, which is covered by the French National Insurance. I'm going to send a flyer in your gift set that'll tell a little bit more about our center, which also includes not only our treatment center, but our R&I facility and our production facility. I also want to share with you that we really do pride ourselves at La Roche-Posay on trying to listen to you and trying to come up with content that we think is interesting to you. And boy, by the numbers of people registered and attending, I think we did a good job of listening. This topic tonight came up organically as a conversation between Drs. Batea, Dr. Siegel, and myself. And once realizing how important this was, I said, boy, if you dermatologists will give a great talk, I will go out and find a light that can be meaningful and helpful for people in their practices. So I hope you enjoyed tonight's program. And in addition to putting those questions in the chat, if you want to share with us other topics that you're interested in hearing about that we can help sponsor and facilitate education and things that can be helpful to you in your practice, by all means, throw it in that chat because we are here to work with you and to help support your needs. So with that, I'm going to turn it over to our speakers, and I think you're going to get quite a bit of great tidbits from this. So with no further ado, I'm going to turn my camera off and pass it to Dr. Neil Batea.
Well, merci, Tyler, and bonsoir, everyone. Bonjour on the Pacific time zone. It's still late out here. And bonsoir, Dan. I can see you there. So, well, thanks for having me. It's an honor to talk about something that's not immunology or high cytokines, which I usually talk about, which I'm going to talk about photography, which is actually a great subject I learned a lot about, not just in the last few years when I've started to do more research, but also just in terms of good images, and especially in the electronic age. And it's been really exciting to learn what to do, but more importantly, we learn what not to do. So I'm going to give you this polling question first. And it's kind of a trick. I think you guys know, what is the best background for a clinical photograph? Is it any wall in the clinic, the light blue cloth background that we are all familiar with, the car windshield, or in front of a window, or it's just really not that important? So give you a minute to answer that. Very good. I'm seeing a good collection of answers there. I think from the satire of my question, you know, some of the frustration when patients are either on a telemedicine visit or taking pictures, what happens when they stand in front of backlight or inconsistent backgrounds when you're following clinical progress or you're just trying to take good images. And I think that's something we'll talk about today as well. So I have to give credit. I'm just going to go back one slide here. Oops, sorry, I think I jumped. There we go. I have to give credit to my brother from another mother, Dr. Ashish Bhatia. He provided me the template for this lecture, but also he's taught me a lot about clinical photography, as has Dan. Dr. Nasir in North Carolina wrote a nice textbook. I've got a lot of good contributions about photography, but I think even more so is just learning from our peers how to take good pictures in clinical trials as well as in clinical images. And the key is using images for records, so we can follow progress. We can take pictures of potential skin cancer for our most colleagues, show with the pathology reports, obviously for website and for teaching. But also if you're really into good photography skills as well as digital imaging, I know Dan is probably the forefront of that, using it as a teaching tool for learning how to expand your horizons. I think for better records, I mean, you see here this preauricular papule, which you would correlate to a potential biopsy site. This helps you not only remember where the excision site will be, but also, again, reassure patients, that we didn't just take out a spot and forget where it was. Again, before and after photos of cosmetic procedures are really the key to really success about patient outcomes. You'll have patients say, oh yeah, I didn't get anything and it doesn't look good. Hey, Dan, go ahead.
I want to make a comment to everybody. This picture is great for localization because when the patient comes back, you see the wrinkles, you see what looks like a little angioma above the lesion, you've got a pigmented lesion down below. All of that helps. If you're into triangulating, don't smear it with purple where you lose your landmarks because it makes it harder. Plus, this nice perpendicular view is really valuable as opposed to the oblique, holding the camera and waving it as you take the shot.
Oh, absolutely. Yeah, you like you see with bathroom tile in the background or everything else. But I think even more so, like, Dan, you do Mohs, and if I were sending you this referral and I'm describing left preauricular, there's still a wide range of where that could be, especially if it's been a little bit of time before the surgery and the biopsy starts to granulate in a little bit. So I like the idea of, the landmark. You see that lentigo at the bottom, right underneath the ear. You can also make a descriptor of how many centimeters northwest of that would be, for example. So it's really important, and even more so with the cosmetic outcomes, just to reassure patients that things actually did happen. But even more so like this photograph where we'll say, well, the rash didn't get any better, or how much improvement did the patient get from our topical therapies. And you see this expanding tinea corporis plaque, but you see a lot of clearing in the middle. Again, this is where you can really follow progress, or if someone's trying to transmit the image for you, you can get a lot of good outcome with describing when do we add therapies or what's the next step in treatment. And I think, again, if you want to use photos, you got to get good consent. And Dan will talk about this a little bit also, but patients nowadays, when someone takes their picture, they don't know where it's going. They're concerned about the potential for it showing up on social media or in a Google hack or not a secure location. And getting written consent to use the photo for clinical purposes only, if it's for the medical records. And then if you're going to use it for teaching, you can get a separate set of consent forms and say, we're going to use this down the road, but I'm going to block out any identifying features on you. I'll block out the date, obviously your eyes, and make sure, if you're using photos in a clinical presentation, you block out their eyes and any other features that would be potentially identified. Also, again, you want to make sure the consent form is thorough, that it is essential for the patient's safety, that they know where the pictures are going and not going. And for publications, you obviously have to get consent form for use in a enduring publication that's going to be irreversible. Obviously, you can't put the genie back in that bottle. The other part of the photograph and the signed consent is, again, the image. Make sure you actually photograph the consent form so that it's enduring also, so it doesn't get lost. And then from here, again, you want to be consistent. If you're following clinical course, if you're setting up for surgery, setting up for aesthetics, you want to make sure the lighting is good, which we'll discuss. The background I already alluded to in the polling question. Positioning is going to be very important, which I'll spend a second on. And then framing the image so that there's no distractions. I mean, unfortunately, Dan and I are both sitting in our office in our rooms where you see a lot of stuff in our backgrounds. But at the same time, it's for the purpose of saying, well, what's the image you want to focus on in the screen? So take, for example, lighting. Again, I won't touch on this too much. Background, again, I already talked about the importance of the blue background. But take a look at the picture here. So you take a photograph in front of that mirror, you have all of the other things that are going on in the clinic room, which can be very distracting to the photo, as if you don't need another issue with trying to interpret that photo. For example, the black background or a blue background is very consistent. It'll be easier to put the patient back in front of it to follow the same course. And even more so, the background should be something that is going to remove any kind of extraneous distracting image or anything else. And it doesn't have to be anything fancy, just something that's going to be a background that's going to be of consistent color and nothing distracting for the photo. But the positioning, I think, is very important. And this is something that, again, you want comparison of the exact same facial expression, hairstyle, no jewelry, anything that's going to say, it's anything different than what you see. For example, with an acne research photo, you want to see that 16 weeks later or 12 weeks later in the exact same position, so you can count the papules and comedones and see how much has been improved. It also gives credibility when you're publishing, so that things look the same and you don't have patient imaging the other way. And there's nothing wrong with the old standard anatomical position, having patients face in that manner. It's very easy to name the axes, for example, superior, inferior, posterior, anterior, medial, lateral. It's very easy to identify those in the old anatomical position that we all grew up with. Same thing here with the Frankfort position. If you're not familiar with that, it basically cuts your face right through this way at the level of the superior aspect of the auditory canal through the infraorbital rim. It's basically in many ways cutting your face this way in a medial axis, but that is the horizontal position that should be straightforward. And again, you'll see a lot of patients, they'll tilt their head down, this and that, and you'll want to just say, hey, look at my nose right here, and you'll know that they're at a straight line with that horizontal position, the Frankfort position it's called. And a good example here of the patient who's looking forward, and then again, a little bit of a 45-degree angle, and then the 90-degree angle. Again, these are, again, you want to capture the images and block out identifying features, but you see a consistency in the angle of the jawline as well as the angle of the nose, and her point of the nose is all on a similar parallel. And then same thing with here, you want to watch for rotation. Same thing in that patient, her hairstyle was back, so you can see her forehead. There was no jewelry, no necklace, no earrings, nothing that's a garment, even anything that would fit in terms of a color distractor. And even more so, again, you want to make sure the whole body is turned, not just the neck, so you're not showing any lines like this when patients rotate their neck around. And then the last thing are the C's of framing. I'm sorry, the last things are the framing and the distraction, excuse me. And again, proper framing is, again, framing so that you fill the field with the image you're trying to capture, but it's not as easy as one would think. And so, for example, here's an edge-oriented frame where you're using the eyebrows actually as the superior edge with this fixed reference edge, so that you see the rest of the face, and it's filling up the entire image. You see very little blue background, which again is good for filling up nasolabial folds, showing a biopsy site, showing wrinkles, but also showing texture of the skin. Be good for showing comedones and milia, for example. This is more the free edge where you see the bottom part of the lip as the lower edge, but again, it's also showing consistency so that you're taking the same photos 12 weeks from now or whenever for the same thing you're trying to measure. And then this is using more the center. So again, using the nasal tip as the center of the image and then filling up the rest of the frame so you're showing everything consistently, maybe in quadrants. And again, this might be better for a full head and neck exam, maybe a chemical peel or whatever you're trying to accomplish. And then again, the last thing is the distractions, which was part of the polling question. I already mentioned about makeup and jewelry, getting rid of any clothing or anything in the background. Stepping in is easier, or stepping back is easier, and zooming in rather than shooting at wide angles. And a good angle of Dr. Siegel right here. You get a nice image of his nice young features as well as his new glasses, which I think are also very impressive. And then again, the LCD it should be your friend, not just looking through the viewfinder, but also using the LCD so you can get a good image from that. And then again, let's look at some photos. Again, you want to use photos as again, building your practice, making sure that you're showing good records. It's helpful for obviously for the Mohs and pathologists that you're working with. And again, you should have fun with photos. It's something that's usual. Let's take a look at some examples. So what's wrong with this photo? Obviously, in a darker skin type, you want to have the proper lighting. You got to have good landmarks of the ear, the hairline, the periorbital distribution. But there's too much blotchiness. There's too much modeling. You're not capturing the image of what's going on with the skin color. Even more so is you're seeing some inconsistencies in the image. It's hard to capture. Good example of tinea versicolor in a patient of color, but yet it's not close enough. One for two. We've got too many distractors here with the bra strap, as well as a little bit more angle versus on the right side photo, a little bit different. You can at least see the blue background, but then you see the light in the top right corner. So again, it's really not a photo that you'd want to say, well, I'm capturing the image that I'm trying to accomplish here. Same thing with the photograph on the left. It's way too much of the innocent skin that's involved and not enough of the nevus. So the photo on the right is a little bit better for capturing the measurement of the nevus as well as the satellite mole, but even more so you're getting some better image of the borders as well as the symmetry of the pigmentation. So probably a little bit better. What I would probably have done though is crop off some of that ruler and make that a little bit less and maybe get a little bit better image of the nevus with the top of the ruler so you can still see the measurements and not the wound measuring words at the bottom. And the same thing here, very inconsistent lighting. It's almost impossible to tell what part of the body this is. And then even more so, this is the eyebrow based on that hair at the bottom left, but you can't really see it because of the lighting and the inconsistent focus. And then same thing here, there you go, good picture of the wart. But again, you got a lot of background. Look at the picture on the right. I mean, this is probably a patient studying in that image. Oh, look at my wart. But then look at all the floor. You got too many colors behind it. And I don't even see the wart after a while because you're so distracted by some of the other image. And then finally, again, this is probably the best image of the webinar. This is Dr. Siegel. So I'm going to put myself on mute, and Dan, I'll hand you the baton here.
Myself. Okay, everybody, let me get the slides going. First, we have a polling question, which somehow it hopped ahead there. Okay, so quick poll. I take images with a cell phone, a point and shoot compact, a 35mm equivalent high-end camera, or I still use film. Poll away. And while we poll, just a comment, when you take a picture, the clever thing to do is take a shot of the consent as the first shot for that patient. Okay, 80% with a cell phone, 7% with point and shoot, 11% with the high-end digital, and 1% still using film. God bless you. My comment here is those with a cell phone, think of a HIPAA-compliant place to store your images, because if you lose your cell phone without having a complex password, you're going to be in serious trouble. Now we have another polling question. I store my images on my phone in the default photo album, naughty, naughty. My phone on a HIPAA compliant vault, good. On my computer or in the cloud. Please vote. And while you vote, I'll just make the other point. When you take the pictures, keep perpendicular. If you're 2 feet taller than the patient or the patient sitting down, be at level with them, because it doesn't help if the patient is level, like Neil mentioned, taking the Frankfort image, but you're standing 2 feet above them obliquely. It's hard for people to wrap their head around. So 14% of you are at risk of losing your jobs. 38% of you are doing the right thing. 30% if your computer is secure are okay. If it's been encrypted, Mac or PCs both will do that. And the cloud, if it's a HIPAA compliant storage area, that's also fine. So let's move forward and we will get into some fun things. So, okay, do I have control of the keyboard?
Yep, you sure do. Dr. Siegel, just click in the middle of the screen. There you go. You're off.
Okay, so just some philosophy first of all. People can play games. Let me just back up. I jumped a little too quickly, but you want to look at pictures in the literature in your own pictures because there are cons out there, some subtle, some not. Example, years ago, there was a presentation on dermabrasion in one of the throwaway publications. And on the left, it shows the woman, the light source is out here, off to the one side, you're getting shadow. You're seeing every pockmark, every line, every wrinkle. But for the post, there was basically washing it out directly on, and it wipes out. So that could have been after dermabrasion, but that could have also been a second after the first photo was taken. Let's see, next one we'll have, here we have, this was actually another one published. That was the first randomized double-blind control of topical tretinoin for photo aging. And if you take a look, it's different lighting because look at the lip on the left. The lips are pretty light on both sides, but the skin around it is very dark. And again, you could have done that by manipulating the image at the time of capture after, and that was the pre-Photoshop days. Now a kid can do that in a few seconds. If you have eyes or a dark surface, take a look at them. While the eyes reflect the soul, your pupils reflect the flash. And a point flash enhances shadows. A ring can wash them out. But again, you can take a ring if you have one and just partially cover it, as we'll demonstrate for you later. Now, the next thing we'll discuss is just confidentiality. HIPAA has made life worse for all of us, and Bill Slew had a nice article back in 1989, which I've adapted the next slide from, to show how what we normally do to anonymize doesn't work well if it's a public figure. For instance, you all know Bill Clinton, Monica Lewinsky, Saddam Hussein, George W. Bush, and our friend Bin Laden down there. Simply masking their eyes doesn't give them anonymity, so keep that in mind. It's so important to have those consents. And ideally, when you take a consent, the best thing to do is take a shot of the consent, all your pictures of the patient afterward, and even take another shot of the consent so you bracket it, so when your staff go to file those pictures in the chart, they know who they are. Now, this is my friend Forrest Brown many years ago. This is actually from a film frame, but just showing some of the games you can play. And this is just part of the collection. You can play with it on your own, but just shows here, you look at this and you say, what cosmetic procedure did I do to Forrest? Well, all I did in the first one, as I said, is just look serious and be a little oblique. In the second one, I told him a little funny joke, and take a look before and after. What wonderful cosmetic results. And again, there are games played, but you want to learn how to capture that. Now, let's talk about resolution a bit, because this is something that's important. Everybody wants, when they get their new phone, they want to have the 42 megabyte image. Do you really need the high-res image? And the answer really is no. That generally is 768 by 512, which is the far, far below the lowest you can get on most cameras, is perfectly adequate. And we'll give you some demonstration. I love math, and you can be looking at almost everything on monitors nowadays. Most people don't even print them anymore. And again, I love math, but most of you don't. But I think there are rules about talking calculus and optical mathematics after 6 p.m. anywhere in the world. So we'll talk about a couple things. We're derms, we're visual. Let's look. We're going to flux the resolution, keep the compression fixed, and follow the images. And let's see how long it takes you to make a diagnosis in this case. A 1 by 1 pixel file, nothing. A 2 by 2, keep going on here and you'll see what we've got. A 10 by 10, no diagnosis yet. Neil, when you make the diagnosis, call it out. So 20 by 21, still nothing. And keep going on here, and 40 by 41, still nothing. And again, it's a small file size, as you can see. 80 by 83.
Oh, I can see the Beatles in there.
Yes, you can, but it's not a good picture. You can't really see detail on there. If we keep going up from that point, 160 by 166, pretty good, and 320 by 332, it keeps getting better. It's getting better all the time. And we just keep going, and you'll watch when we get up to about the 768 by 512, the Bitdorf number, it looks pretty good. And as we go beyond that, well, it doesn't really get a whole lot better. So again, we're sort of proving to you that you don't need massive size images. This is 1024 by 768. And again, the only importance going beyond that Bitdorf number is if you need to zoom in and do some manipulation afterward. So basically more is better up to 768 by 512, but increments beyond are marginal when you project them or look at them on a screen. Now, what about compression on here? Let's say the other side of it, because you all know, your phone compresses images at the time of capture. You can capture in a native mode, but they tend to compress JPEG. It's like a sponge. It squishes it down, and when you open it, you're seeing it, but it uses a funky algorithm to make sure that, it's squished a lot. We won't spend, again, we can go on for hours, but I won't dazzle you with mathematics. We'll just show you more pictures. So here's the native image, and take a look. It's 811,983 unique colors on there. If we compress, now this is 95% quality, 5% compression, using a Windows program called Irfan View. And if I keep dropping the quality and increasing the compression, you're not seeing much of a change yet. In fact, as we go through, we will get down to about 25% quality before you start to see any change. So again, this image is getting squished and compressed and then opened up again, but no real difference as far as the naked eye can tell until we get down now 20%. It's starting to get a little fuzzy. Paul's getting a little more, shadow on his cheeks there. 10%, 9% quality. You keep dropping it, and this last couple percent is where you really start to see things drop down in quality, and we'll see side by side in a moment what we look like here. 5% quality, 3%. You see you're losing quality. The compression program is kind of mucking things up, and you're losing what you want. So at 1%, we only have 20,000 colors. But if we take a look at the native image and the 25% side by side, they look alike. And if you go ahead and you zoom in even further, you take a look at this, we blow them up, they still look pretty good. It's when you really zoom in really close. So we'll zoom in on the boys up in the upper left-hand corner, and you'll take a look at that and compare it. And now you'll see a difference on the high compression, but you're not looking at the image like that. It's like if you look at a billboard on the highway, it looks pretty good, but if you stand right up to the billboard close, it's a bunch of dots, and the same thing here. But you don't need the massive images you can capture because storage, especially in EMRs, when you have to pull things up, it takes more time. And again, this just shows the graphics, pardon the math, but it shows a sweet spot around that 20 to 25 compression range before you get that steep drop off on there. And the naked eye can't tell the difference on there. So a short story is a single megapixel is enough, and we published that years ago. If you want a good book, if you want to read all about this in detail, Paola Pasquale put out a medical photography book about a year ago. That's great. So single megapixel is good, but higher res, if you can, fine. This is Neil and I. This is how they transport Neil and I around places at meetings. They decide we deserve the respect we've earned. So we get to sit in the back of this, and they do warn us when we're going to hit a bump. And now Neil and I would like to go ahead and show you the toy you're getting from Roche-Posay tonight. This is really neat, and we talked about light. So Neil's going to show you his phone, but I'll give you a demo of the toy first. This is what it looks like from the front, the side view, and the back. With one simple switch, it charges up with a mini USB that you plug into the computer. And Neil, do you want to go ahead and show everybody? You don't need to have it plugged in. It should be powered up, but I'll just flip it on. A single click gives you one level of light.
And you get a nice bright light from there. Obviously, this is the image you want to look at there, and here's the light shining on it. And then the next click takes it a level up, and we got a nice, even brighter image. Third click takes it even further. We're getting into the spelunking mode here, which is good.
And the fourth click turns it off, but if you don't click but hold your finger on it anytime, it has special effects. Stop, Neil, stop it. Okay. Well, but basically you won't be doing that in the office very much unless you're doing neurology on the side, but it is great, and it can fit over even a camera with a big bulky case. It can fit over. And again, if you're taking this picture and you say, gee, didn't you say a ring washes out shadow? Well, you go ahead and you go and grab stuff, maybe duct tape, maybe surgical tape or electrical tape, and you can put a piece of tape over it. So you just pop a piece of tape over, and suddenly you no longer have a ring, or you can block off half of it or 3/4 of it, or you can block one side for shadow. You can get pretty clever with it, but it's great. It fits anywhere. And if you want to, you can Halloween, you can be the Borg, you will be assimilated. But it is a great, useful little device, and there are some advantages to this that you don't have with the ambient light, because when you're in the office and you're a resident and you're swirling the camera around and it's blurry, it's underexposed or overexposed, because the camera is having to constantly recalculate. This way you've got a bright light lighting up what you're doing, you can control the illumination, and the brighter the light source, the shorter your exposure, which means the less shake that shows up, the crisper the image when you zoom in. So it's a better image for publication. But again, a useful device, and everybody who is in the US who is on tonight will be getting one of these lovely lights, and it'll take about 8 weeks to deliver. So please do not email Tyler, Neil, myself, or Roxanne every day saying, where is it? Give it 8 weeks. Exactly. And I do think that we've got a bunch of questions coming in. And
we sure do. Again, if you want to submit your questions, use the question chat pane on the right-hand side of the screen, and any additional questions that you think about afterwards, you can send it at info@rbcconsultants.com. Again, we would like to pass to the question period right now. So I'll stop sharing my screen. We've got one question. How do I present image washout?
Okay, image washout is when you have too much reflection back. So what it means is either your light is so close, you're getting too much washout. So as the camera averages the exposure, the edges might be good, but the center is overexposed. One possibility, and with this camera, is that if you're doing it with your cell phone camera, you can simply, if it's washing out for some reason, the skin texture, the patient's skin's too oily, move the light off to the side. That's perfectly fine to do that, and that will give you actually some more contrast. As we showed before, look, I have no acne scars. Look, I do have scars. Again, where you keep the light plays a role, but you can prevent washout. The other things you can do, if you've got, those of you who have mostly using a cell phone, but if you're using a mini, a compact digital, one of the clever things you can do if it's dedicated is you can take a piece of sandpaper and just buff your flash. So instead of the flash being very bright and focused, because the flashes on compact cameras are usually designed to be optimal between about 5 and 10 feet, and you're usually closer for macro stuff. So if you basically buff it and rough it up a bit, it diffuses the light more. If you don't want to wreck the camera, take a water bottle, and when you finish the water, take, again, sandpaper, nail file, rub it and basically make it a little opaque so it basically looks milky looking, cut it out and just tape that over the flash. Great ways to diffuse your light so you don't get the intense washout.
Yeah. So yeah, but as a rule of thumb though, what would you say about distance? So if I'm thinking about it, let's say I've got an EVIS here, I'm trying to keep adequate distance. I mean, I like the idea of separating it from the phone, but is there an image distance that you would ideally start at?
I would think that you would probably, for an EVIS, you probably want one distance shot that will show where it is, and then you'll want to zoom in to see it very precisely. So what I would probably do in that circumstance is I would probably, when you work with this, is see what works better. But also, I wouldn't hold the phone like this. It's like when you watch a shoot 'em up movie and the gangsters are holding the phone in like they're flicking the knife gun. Brace yourself. Grab the phone. Hold the phone like this, whoops, your phone this way, and hold it so that you're stabilizing it. Brace your arms in, brace, because if you're holding it like this and it gets shaky, you wind up with a blurry image. So instead of getting to go to a nice meeting in a warm climate, you're stuck at home because you have crummy pictures. So again, brace yourself, take the picture, and again, take it perpendicular. If I want to take a picture of Neil, I want to be straight on. I don't want to be looking down or some oblique odd angle. I want consistency, as Neil mentioned before.
Yeah, I mean, because we're not taking selfies and we're not in the subway station going like this, for example. We're, holding it like this. You could have your medical assistant navigate the light at the angle that you think is best. So it's also a lot of, error that comes from the wrong operator.
And if you want a light source that you say you want the consistency, well, you could easily take it and have the camera. You can, if you're clever, you can adapt. You have something that keeps it just above the case and just have a brace or bracket on there. Lots of things you can do if you have, I mean, if you're doing a lot of photography, this does make life easy. You can keep it in your pocket or even have a dedicated phone. I've recommended to people that when they upgrade their phone, instead of turning in the old one, if it's not worth that much, just dedicate it to photography and use that for your medical photography. You can make that secure, put a funky, fancy password on, or anything to do. It's a good, secure thing to do, and it lets you repurpose the phone instead of it winding up at a dump somewhere.
Yeah, exactly. Well, and probably be sure to remove the SIM card and anything that might transmit. Then that way you can just plug it into the office computer and download from there.
Can a pigmented benign lesion be distinguished from pigmented cancerous lesions such melanoma using a photograph?
I think conventional wisdom would say that's the job of the dermatoscope more than a photo, but a photo, especially for preparing for surgery or referral or comparing image to something that maybe have changed, you could definitely use that to say, well, let's use the clinical judgment to maybe make the decision to biopsy or fully excise it. But I think the better image for those decision making probably comes from the dermatoscope. Dan, I'm sure you would.
I would agree that I prefer the dermatoscope, but on the other hand, there's a number of AI programs that have come up, companies like Skin Vision and MetaOptum and others. Skin Vision, for those who are in Europe or Australia, New Zealand, you've got it, it's a medical device. A number of AI programs come up that will look at a number of factors, symmetry, color change, many features. And many of these AI programs and clinical images are actually better than all but the best among us. And that will only get better as time goes by. And that's happening not just in derm, but in pathology and GI, lots of areas.
A really good question. How do you organize your images?
If you have an electronic medical record, they probably go in the chart. If you've got Emma, for instance, one of the more common ones, and again, disclosure, I have to work with the company there, you can take the iPad that you're using in the office, pop your light on to get even a better picture, take a picture, and it goes right into the patient's chart. If you're not electronic, or you have a non-image friendly program, or it's an institutional program where you want to keep some images that are not part of the record, I would consider storing them either a HIPAA compliant cloud storage site. There are some HIPAA compliant apps online, depending on whether you're an Android or a Google user. There's a lot of things out there, but whatever you do, it should be password protected. It should be secure. And again, if you're in an institution, you're working for a large group, or you're in an academic setting, secure is not simply secure, but it's secure as defined by your institutional privacy officer that will keep them happy. Which means don't go keeping every image on your phone. If you use your phone and it's secure, download every day, remove them from your phone. You shouldn't be looking at pictures of patients in the elevator or in the bar. Not good behavior.
And that's the one hard part about the phone, is there's no timestamp. You have to really be cognizant about when did you take the photo, and probably try to upload them to the filing system you have on a hard drive as soon as you can. I think one of the things we do in research studies where we take dynamic photos or timing photos of reaction patterns, for example, with Botox or something else that we're trying to get an image of, is you have to make sure that you have the filing system in place so that you have them labeled, so that the files labeled, so that you can get those photos off and into the right files as soon as you can. Because the wrong file, the wrong photo in the wrong folder will screw up all your data.
Now, one thing I'll disagree with you a bit on, Neil, is that although you don't have a timestamp on the picture, if there's ever any medical legal issue, somebody simply opens up, like on the iPhone, and you can take a look, and you have all this information there that shows you the camera taken. This image I popped up, wide angle, 28 millimeters, 12 megapixels. It gives the date and time to the minute, and if you have your location on it, it will geolocate it for you. So remember, that's all built in. And as a reviewer for a number of journals, nothing is more fun than getting an article that's totally outside my area of specialization. And it's usually something where the pictures are just too darn good. And then you get to play forensic person. I was asked for the native images. And this happens in the Blue Journal a few years ago. There was a paper that looked at injecting warts with antigens. And an astute reader, wasn't me, some other astute reader sent the editor a note that the before and after were on a very ornate, beautiful oriental rug, and the location of the foot was exactly the same before and after, and basically it was a doctored photo. And you can even take the image, open them up, and in a number of programs to see what the manipulation is. When you use Photoshop, it builds into what's called the metadata, all the information about any changes done to that photo. So it's harder and harder. If you're going to be crooked and dishonest, at least cover your trail.
Yeah, no kidding. Well, yeah, that's a good point about the labeling of the photo within. And I think you get to the point where if you're not showing a sequence, or at least can prove the sequence, then that's really going to be detrimental to your records.
Do you have any good cheat sheets for proper photo taking techniques that we can share?
I don't have cheat sheets, but just, again, the certain common sense things like Neil mentioned. If you're using your iPhone, well, for head pictures, always take a vertical shot, not a horizontal shot. You don't want all the space around. And you may get in the habit, portrait mode gives nice results, but you have to be too far back. But get in the habit of, zooming in maximal optimum, optical zoom. You don't want to go into digital zoom, because digital zoom essentially interpolates and guesses what should be somewhere. You can go to maximum zoom and back away, which gives you the equivalent of a longer lens. In the old days, when you bought a camera for general derm, you get a 55 millimeter camera, which is the same view your eye has when one eye is looking through the lens, the other eye is open. But that foreshortens things and gives you sort of a squished look. So for portrait work or for surgery, you'd use a 90 to 100 millimeter, which is the equivalent of the way your brain integrates the two images together. And since most, camera phones don't really have it specifically out there, you get into a stance where, for instance, in your exam room, you might be 3 or 4 tiles back from the patient. And again, you zoom in and you get to the point where it looks good. You look at and they look at the camera, they look alike. That's a good perspective, but capture it, capture it there. But you don't want the oblique, the head up, the off. You want to show things easily because you're using it either to show a cosmetic result, to teach, or to show a surgical result, and you want accuracy on there. And again, don't doctor pictures after the fact for publication.
Well, it's harder to, when people are freestanding or you're in a clinic, exam room, it's not like the Canfield or some other, sitting photo where they have a chin rest and it's going to be consistent where their head and chin sit, and it's going to be the same. But at the same time, you can still have those marked in the room, for example, or, again, just making sure the patient is looking leveled up, like the Frankfort position, and, focus on the nasal tip and let that be your guide for consistency each time. I think it's about mirroring the image of what happened last time to show.
And if your rooms, let's say you've painted your walls a nice shade of light gray, which happens to have 17% reflectance, what's called neutral gray, you could have the patient stand against the wall, and you could have a line on the floor which the camera is parallel. If you decide you really love photography and you decide to move up to even one of the compact point and shoots, you can often have presets where you preset the focal length, or for instance, you go to maximum zoom and move your body in and out so you frame at that perspective. There are many ways to make it work for cameras. I always recommend that if you're going to buy a new camera, I mean, you're buying the phone for many reasons, but the camera for a particular purpose is go to your favorite stop, be it Best Buy or wherever, or local camera store, bring with you a fair skin friend and a skin of color friend and see how the camera does. Because if it's a camera that really adapts well and you take the picture and what you're seeing on the little LED looks just like your friend, that's good. But if your skin of color friends are pale and pasty and your very fair skinned friends are darker, well, it's averaging the way you don't want. Then again, you can have manual controls. It takes reading the manual for your camera. And there are many websites that have tutorials for almost every camera, like Steve's Digicam, that can help walk you through how to run it through its paces.
On that note, do you have any tips to photograph patients of very dark skin of color?
Well, I mean, specific tips go back to lighting, about capturing the image first, making sure that, again, not just like Dan and I were both saying about the angles, making sure the background is consistent, but I think you want to make sure that there's not inconsistent lighting, like one of the photos I showed earlier on what not to do. And it also is a matter of capturing the pathology. For example, if it's a solid growth, you can make sure that it's focused on the amount of skin type that it's there, so it's representative. But it's more of a diffuse rash, like the tinea versicolor patient we showed. Make sure that minimizing any distraction of the background that could change the lighting, making sure that there's enough focus, and then I think even more so, maybe taking one image that's a little bit more distanced, but also to maybe taking something a little more close up so that you show the pathology a little bit separate from some of the background innocent skin. I think those are just a few series of photos, for example.
If you're a camera person, there are lots of apps that let you play like you have a real camera. And one that I happen to like for this purpose is something called 645 Pro. And again, you can see me on there and you look at the interface. It has a lot of buttons and things. And you can go ahead and you can set your exposure. So for dark skin, you may open up what you used to say in the old days, open up an f-stop or two, which basically means let more light in. And again, you can get it to the point where you see which setting works, save presets, and take those pictures. Because again, you really need to adapt for the local conditions. But remember, the ambient light is generally a problem. Unless you've got a broadly sunlit room, which even that, the color temperature, the color saturation changes over the course of the day. But fluorescent lights give you a sickly green hue that the camera, all digital cameras will compensate for that. Incandescent light gives you a romantic yellow glow that's again compensated for. And again, what's nice when you have an external light source is this, which is pretty good white, bright, daylight type light, compensates for it by giving you, since it's really bright light, think of it this way. If you've got the room light, which is the overheads at 8 feet high, and you've got this, let's say this is the predominant part of the lighting, so this may be 95, 98% of the illumination, whereas the overhead lights are only a few percent, so you're not getting color alteration or distortion. And keep that in mind, and again, the brighter you can take the picture, the quicker the shutter fires, the more stop downs, the greater depth of field. And for depth of field, those of you who that's the first time you've heard that phrase, that is an idea of how far from front to back you can actually watch. So if you have the aperture wide open, so you're getting light from every which way, what'll happen is you may take a picture of my nose and the tip of my nose in focus, but my mustache and everything behind is blurred. On the other hand, if you stop down to a little tiny aperture, only parallel light waves go through, and everything from the tip of my nose to my ears could stay in focus. Again, it's much harder with a cell phone camera than even a point and shoot would be, because you'd have less control with the built-in cell phone camera setup.
Yeah, but you bring up two good points, Dan, about distracting light coming in from other sides. Like, for example, if your exam room has a window in it, that's going to bring a whole different source of light to distract from the sides, for example. or if you have can lights above versus fluorescent lights or big, bank lights, it's going to be very different lighting also. So that's probably something that has to be, made consistent for everyone, and maybe just have a separate room for that, even if it's a small closet or what have you. Because that would really distract from the photos.
Yeah, that's the ideal, because you have a separate room. You could have a camera that's set up in one fixed position. You can have lighting around the room. You can control it. Again, but again, it depends on what arrange. Like for instance, when you're doing cosmetics, many people have the Canfil Visia, which is a beautiful system. But if you're doing Gen Derm and you're not doing much cosmetic, you don't need to spend that much. I mean, much of what we're doing is for showing what's been done for medical legal reasons. And electrons are cheap, and a picture, even since finishing my residency, everything I've ever biopsied, I'd photograph. Why? We can find where it is. There's no question of the location. Because again, nothing is more annoying as a Mohs surgeon than getting a referral and the path report says left face, and the patient's face is a minefield with lots and lots of keratoses, lots of scars. And where's the biopsy? The patient says, "You're the doctor, you should know." The picture helps me know. And if I don't know, I take a picture, I mark what I think, and I send it back to the doctor referred and say, "Is this the right place?"
Yeah, no, exactly. I mean, even for the novice photographer, like many of us, just good pictures of nevi, pictures of pre-biopsy site photographs, and then of course just to follow progress. The 3 good uses of photography. But you showed some good utility of the phone with some apps that change things, like a good expert photographer used to do on the old cameras, 35 millimeters, and change aperture, change f-stop, and what have you. I think a lot of us still could use a little primer on where some of those apps exist.
This program is 645 it's a lovely program. It's inexpensive. 645 Pro it's called, and I have no financial interest, and it's just nice because it gives you some creative controls on the camera. Again, depends what you're doing, because I always tell my residents that bad pictures don't get you to go to meetings in warm places in winter. Good pictures might. Try to get them good, because it's that first time. Editing and being creative on pictures is not fair. That's not kosher. So again, brace yourself, take that picture, holding it steady. Don't wave the phone around like you're saying, "Hi, mom, hi, mom." You want to brace, stabilize, because even the slightest bit of movement, when it shows up on the big screen, you see the blur, and you don't want to do that.
The big point you made too is that it doesn't always have to be on the phone. You can hold the light separately, or have your MA or somebody else hold the light while you hold the camera to optimize the image.
That's an idea. You could probably put a sweatband on here, and you could probably have, you could wear it just like the ENT docs would have. You could have it, and you could illuminate, and you could control the light and just work it out. So many ways. I mean, this is going to be a useful toy in your practice.
I mean, this is a nice party trick. You show up with this light, and it's like, well, I'm all lit up to see it, so it's good.
If the party's dull, you hit the button, and you get everybody dancing.
Get it on the strobe light.
Yes.
So what program do you use for before and after photos side by side?
I guess, Neil, you probably do that more in studies.
Yeah, I don't know if we don't have a set program, for example. We just kind of have the template that we work with each sponsor or such, because we have to reproduce them in a way that doesn't look like it's templated or what have you. But I know there are some good software programs that you can download. I don't know specific ones by name yet. I know there's some that catalog photographs either alphabetically or by date or what have you. So there's many different ones. I'm just not as familiar with the names of those.
Well, and, I think Sam Canfield's old dermographics even did it years ago, where they could do comparisons, do differences. But you could look into the properties, see how many colors there are. I've often found that just opening a PowerPoint and popping them side by side, and you can even overlay them and play with transparency to compare things if you want to. Again, when investigating. But for most times, like if you're showing a patient side by side, you can even have just open PowerPoint, just drag them in and adjust in size. Lots of simple ways to do it. The thing to avoid is using programs like Photoshop that let you manipulate them. Resist the urge to manipulate. That will get you on journal editors' blacklists.
Well, to that same point, is there a difference in how we store the photos? I mean, should they be JPEGs or some other file, that they should be stored as? Because there are some file systems that store them as PDFs, and that's also a little bit tricky, but it also saves on file size.
But the problem is when you store as a PDF, you get to select the compression and resolution, you may be losing quality. Again, most cameras will will capture, the default is as a JPEG. Many will let you store as the native image, what's called a TIFF file, but TIFFs, there can be proprietary versions of TIFFs, which are non-compressed. Bitmap is another storage image that can be uncompressed or compressed. Most don't even think about it. JPEGs are the most common. But again, when you get to select on your phone how big an image it will be, the bigger the image, the less compression there is. And you can capture natives, but it can be massive storage. And if you're taking thousands of images a year, that might start weighing heavily on the server where you're storing things and may annoy some of your administrators. And as we showed you graphically, you don't need super high resolution, but you shouldn't be messing around. In other words, stay consistent with whatever your resolution you're doing, but don't start editing after the fact. I mean, once you've captured for the medical record, that image should not be touched, should not be manipulated for medical legal reasons.
Exactly.
Also, our photos on EMA store a lower quality, so their EMA has low quality. Is there a way to change this? We are using ring light already and use good technique. It's just the EMA platform.
While I've worked with the company, I don't use it because I'm now at the VA full time, which has its own picadillos. But I would contact your support person and ask. And if it turns out that they're compressing too much for your satisfaction, you can always just, again, dedicate a separate device. Get yourself a camera. Get a nice, compact camera. Panasonic has some wonderful cameras with amazing zoom capability. All have good macro. And again, go to the store and test, because sometimes the good macro that sounds good spec wise, it's a nuisance. In other words, some cameras will have a narrow range of focal length at which it'll let you zoom. Find the one you like and just capture those pictures and have a separate place to store it. And again, separate place, that can just be on a well encrypted computer that gets thoroughly locked down with password or other protections, and just store that in a HIPAA compliant manner.
Are there any resources to learn more taking photos in the dermatology setting? Any textbooks that you would recommend, or?
Well, I would involve in one. Yeah, I mean, Dan's written a bunch of articles.
Paola Pasquale's latest textbook, of which I and associates have 2 chapters in, that actually are fun reads. It's a really good book on medical photography in general. One more point actually on images. We're one of the few medical specialties that just captures images without thought to standardization, in that radiologists use what's called DICOM, which is a standard where the image information is not only shows up on the X-ray letters, but it's actually embedded in the image. And there's different standardization, different storage standards for it. And many of us are involved in ongoing discussions to maybe see this happen for us at some point, but we're not there yet. But right now, your JPEGs will hold as long as they're consistent. What you don't want is you get sued for something, and then the lawyer says, oh, all these images are dated, 2014, except this one, which was edited in 2022. Why did you do that, doctor? Once you store the image in the record, it should remain there untouched, just like your notes. You don't edit things. If you do edit the image, save the original and label the other one clearly as opened and edited on such and such date. Opening and closing doesn't change the image when you shut it down, but any editing you do will change it, and that is often trackable with the built-in metadata.
Yeah. So
one last question. Sorry.
No, I was going to say there was a book chapter I was involved in with Jeff Dover and Kavitha Marwala, was Business of Dermatology. We were involved in that chapter. It's pretty good, just synopsis of how to get basics of photography into the practice and use them to your advantage. But Dan's written a lot of articles and made a lot of presentations on these at different meetings. So it's important to find these handouts and track them down, because they have a lot of information.
Any recommendations on how to share pictures with another clinician while still compliant with HIPAA?
Well, if you're in the same system, you're in the same environment where it's on the EMR, they may well have a link to it. In other words, I can look at any picture in the VA anywhere on the planet. If you're using Emma, anybody in the group can log in. And keep in mind with EMRs, every EMR that's a certified EMR has an audit trail which tells who did what when. It audits down to the keystroke. So don't think that you see that your cousin's in there and you want to look at her pictures. If you do that, it's going to trigger. And if you didn't have a scheduled appointment with that patient, somebody's going to get an alarm that says, you went where you shouldn't have gone, and that could cost you your job. But again, sharing within the same, environment works well. If you have to share outside, you can do things like you can compress and encrypt. For instance, make a picture and zip it, and then make it password protected. But have a complex password that you share. If you're sending the picture from, your computer, you might text your friend the password and say, the picture I sent you at 10:40, this is the password. They can copy and paste. I say there's different ways to do it to make it secure. But again, if you're in an institution, check with your information security officer, because your institution may have more stringent regs than the HIPAA law itself has, and that's what you have to follow to not get in trouble.
And one last question is, why are my pictures blurry?
Why are your pictures blurry? You're probably moving around, or even if you're rock steady and it's low light, what's happening is you have a long exposure, and we all have little fasciculations. Even if you're rock steady and you can take a Mohs layer that's thinner than toilet paper, we all have little, the muscles are still twitching at a background rate. And with low light, it's a long exposure. A good exposure with, again, an external light source, or even the built-in flash, which washes things out a lot. But you can have an exposure that's like 1,000th of a second, which means there's not a lot of time for shake. But if your picture is taking 1/30th of a second, it's going to be blurry, and you can practice it. Go in a low light room, just do a selfie, and then do another one with the flash going off. It's the brightness which controls the exposure length. The brighter it is, the quicker the shot, and the darker it is, the longer the exposure.
When you mentioned portrait mode too, Dan, within portrait mode there are little settings of light. That you have natural light, or you can adjust for that.
Right.
So even for the amateur, I mean, there's very simple techniques you can use to adjust the light. But yeah, 2 hands.
Right. The problem with portrait mode is that you usually have to be far back. It won't let you get the close-ups you want with that.
Right. Yeah. No, that is the one downside. But you can control the distractions from the image, and then just take another one out of portrait mode with a little bit of distance, just using the right background. So I'm a big, again, we talk about the right images. Right images doesn't just have to be one. I mean, one that's a close-up, one that's a little bit more detached, will give the overall picture.
Right. Now, if you've got somebody with psoriasis and you're tracking how they're responding to treatment, you may want a whole body photo, but you may also want some close-ups of recalcitrant areas, unusual areas. Again, it depends on the purpose of the image. If you've got an interesting pigmented lesion you plan to write up, well, you want a clinical and a dermoscopic image, and you can still just take your phone over the derm light and do it. There are lots of ways you can do things without great difficulty. There are attachments for the different dermoscopy devices. Dermlight makes a wonderful little magnetic attachment that you can hook onto any phone, and you can use it on the phone or even on any point and shoot camera. If you're doing a lot of pigmented lesions, my recommendation would be to either dedicate your last generation phone, or to just get yourself a good point and shoot that is compatible, meaning the lens is not moving out much, it's kind of locked in position, and make that your dedicated dermoscopy camera.
Well, that's all the time that we have together.
Darn it.
I would like to thank Dr. Siegel and Bethia for a great practical presentation. Also, La Roche-Posay and Tyler Steele for making this educational event possible. And thank you all for participating and attending this evening. Good night.
Good night, everybody, and bonsoir, Roxanne.
Bonsoir.